Good morning to all of you. I am Paresh Prabhugaonkar. It's a matter of pride for me to speak to all the eminent faculty and distinguished delegates who have gathered virtually for the academic feast today. On behalf of PharmaFir, it gives me an immense pleasure to welcome all of you for this live webinar on bleeding disorders. I extend my warm welcome to Dr. Biguzi, who has been kind enough to agree to spare her valuable time with us today. She will make her intellectual contributions to the content of the webinar. Also, I would like to invite none other than the most celebrated face of hematology in India today, Professor Dr. M.B. Agarwal. Sir needs no introduction. He is an institution in himself, and he will briefly summarize the Indian context to bleeding disorders to set the ball rolling. Thank you.
Thank you, Paresh. I'll just share my screen and begin. Can you see my screen?
Yes, sir.
Okay. So good morning to everyone.
Good morning.
Today's guest speaker is Dr. Eugenia Biguzi from Milano, Italy. This webinar is brought to you by Mumbai Hematology Group. It is supported by PharmaFir and it is managed by Mice Ideas. I am thankful to Mr. Paresh Prabhugaonkar and his team from PharmaFir, Mr. Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker Eugenia Biguzi from Milano, Italy, our chief guest for the day, Professor Dr. Niharika Gill, discussants for today's webinar, and all of you for sparing your Sunday morning. Just to introduce our next weekend activities, Dr. Angela from Mayo Clinic, Rochester, Minnesota will be speaking to us on monoclonal gammopathy of renal significance and Poems syndrome. That's on Saturday, 27th February from 7 p.m. And next day on Sunday morning from 11:30 a.m., we have Professor Dr. Aristoteles from Germany to tell us about advances in management of myelodysplastic syndrome. Discussants for today include Dr. Srimati Shetty, former scientist F, Deputy Director, Senior Grade, Department of Hemostasis and Thrombosis at National Institute of Immunohematology, ICMR, KEM Hospital Campus, Parel, Mumbai. Dr. Chandrakala S, Professor, Department of Clinical Hematology, KEM Hospital, Parel, Mumbai. Dr. Ankit Rayani, Consultant Hematologist and Bone Marrow Transplant Physician, Cure Hematology Oncology Clinic at Ahmedabad. Dr. Abhishek Dudatra, Hematologist and Bone Marrow Transplant Physician, Cure Hematology Clinic, Sterling Hospital, Ahmedabad. And Dr. Dheeraj Bhatted, Consultant Internal Medicine and Hematology at Sir H.N. Reliance Foundation Hospital and Research Center, Girgaon, Mumbai. To introduce our guest speaker, Dr. Eugenia Biguzi, to you now. She is a specialist in hemorrhagic disorders in Milano, Italy. She works with Professor Flora Pevandi, who was our speaker a couple of times in recent past at the Hemophilia and Thrombosis Center, Milano, Italy, at University of Milan. She did her post-graduation in medicine from Pavia in 1993. She worked in pediatric hemato-oncology. Subsequently, she moved to Milano and joined Professor P.M. Manucci's group. This was the beginning of her work on hemostasis. She developed a passion for hemostasis, a subject which she hated earlier. And in her own words, lots of clinicians not directly involved in the care of patients with hemorrhagic and thrombotic disorders suffer from this hate. Today's quiz for all of you who are interested in. So I'll put the quiz to you, and as usual, you will be answering on the email ID that I will show you. And the first correct answer will get the prize. So this is a child (12 years old) from Srinagar, was seen for gum hypertrophy. Investigations showed acute monoblastic leukemia. Patient received usual treatment using 7+3 protocol. On day 14, patient had severe pain affecting pelvic and long bones. MRI of the bones and a bone marrow examination were done. We will show you the MRI and we'll also show you the bone marrow picture. And you have to give a diagnosis of this pain affecting the pelvic and long bones on day 14. Okay. So this is the MRI of the long bones, legs. Another MRI of the long bones, legs. MRI of the pelvic bones and the upper femur. And the bone marrow biopsy. You have to forward your impression on MB Agarwal, MBA GARWAL 1 at gmail.com. And now, our chief guest of the day, none other than Professor Dr. Niharika Gill. To Mumbaikars, she does not require any introduction. And also to the Rheumatology Society of the country, again, she requires no introduction. However, to complete the formalities, she is Professor and Head Department of Medicine at KG Somaiya Medical College, Mumbai. She graduated from Topiwala National Medical College and Nair Hospital in 1984. She completed her post-graduation in general medicine from the same institute in 1989. She specialized in rheumatology under the guidance of Dr. V.R. Joshi, the most respected name in this field. She's a recognized undergraduate and postgraduate teacher with MUHS and for DNB. She was given an award by the Governor of Maharashtra, Shri Vidyasagar Rao, for spreading awareness of arthritis in the community. She's appointed as a teacher on osteoporosis awareness through the International Osteoporosis Foundation. She was the secretary of Association of Physicians of India, Mumbai branch. She has several publications in reputed national journals. She is an invited speaker, panelist, judge, and chairperson at various conferences in medicine and rheumatology. We are privileged to have her to inaugurate today's webinar and give the words of wisdom to all of us. So thank you so much. And now I'll stop sharing my screen and over to Professor Niharika Gill.
A very good morning, everybody. And thank you, sir, for such a kind introduction. And you must be wondering, what is a rheumatologist doing on a hematology platform? Ladies and gentlemen, before I delve into the subject that sir wanted me to talk on, I would briefly like to describe how I happened to be given this honor. We all had our brushes with MBA sir, genius, in our formative years as a physicians. But come lockdown, I began to feel, why not update myself on every subspecialty of medicine that there is, given how so many nuances make their way into the field every single day? More so when top-notch content was accessible through a virtual media Goes without saying, when it comes to hematology, Agarwal sir was the obvious choice. One day he says to me, Niharika, I've observed not too many of our students take up hematology. So you are a teacher who engages both UGs and PG students. Why don't you share your insight on this one of the webinars? Sir, there really can be no greater honor for me that to be called upon by a teacher to address such a gathering, and more so when the teacher is someone like you. The day I was assigned, I took it very seriously. I decided to actually assess if the takers for hematology were truly that few by generating a Google Form survey and circulating it among my students. So there were 75 students which I had surveyed. 25 were the third MBBS students, 25 were the one who have just completed MBBS and entered internship, and the next group was the one which were appearing for the NEET, because these are the students whom we have to catch them young because they are in the formative period of their education. And the result of the survey sadly did show a poor preference rate for hematology. Only 12 students opted for hematology. Ever since, I have actively tried to take more classes on topics in hematology for my UG students. And it based these that I'm sharing my insight to you all. And before I start speaking about the survey, I really thank with my bottom of my heart Dr. MBA sir for allowing me to use all his slides for making this subject interesting for my UG students. Around 70% of the students cited lack of awareness about the field as the cause for a poor preference towards hematology, while almost 70% claimed they lacked interest in hematology. And additionally, a few students believed that there was no scope for the field in the future. And that, in my view, is greatly because the current generation has not been exposed to us stalwarts in the field. And this, I took it as a personal, desire that I should do something for my undergraduates and PG students because they were our future doctors. No matter how much, that's what I told them. No matter how much a technology flourishes, will expose to a good teacher and leader of the field has a different insurmountable power on the students. Another reason the students cited was that their perception of hematology is that it is a branch requiring little clinical skill and more of laboratory analysis. See, this perception was so wrong among the students. The perception is that it does not give the satisfaction of diagnosing a patient. This again roots back to a poor exposure of students to hematology. What they also is unfortunately that impressed them is that just like clinical science, reading and interpreting lab report is also an art. In the present era, we have been attempting to salvage our eroding clinical skills. But in the process, we must ensure our students appreciate the art of interpreting a logical done investigation, something that can be equally thrilling, brain teasing, and satisfying. So this is what, sir, I have been trying to inculcate in my, in a very small way in my PGs, that it's really a very interesting branch. And somewhere down, I feel in their first MBBS and second MBBS, they are really not making the hematology subject as a very interesting subject. So if we truly wish for more of our students to lean towards hematology, principally we as a teacher community need to reach out to the student community. So this is I'm speaking from the heart as a MD teacher, not as a DM teacher, because the DM teacher will be having different goal in their mind. But for the UG and a PG teacher, we have a different goal in our mind. So I was greatly surprised that students felt there was a little scope in hematology in the future, particularly given how gene therapy and artificial intelligence are coming up in a big way. And that I think stems from the basic lack of awareness. Too often, we are so preoccupied with exam oriented teaching that we forget to expose our students to the nuances to the field. The excitement of AI and the gene therapy could not be also ignored as a future advancements in hematology. I'm fully aware that the changes that I'm asking for need excessive collaboration and a collective action and a major overall in our site. So these goes to all our teachers who are attached to a BMC or a government hospitals or to a corporate hospitals or a private medical college. But that is what we are here for, isn't it? And if I can even stimulate our thought process and help just one student in the process, I would have achieved more than what I would like to. And I, with this thing, I had really made one of my PG students to take up as a DNB topic for his thesis, a hemat topic, so that at least he is the one who gets little passionate about hematology, and future I may see him as a hematologist. I once again thank you, sir, for having a deep impact on our lives that we have. This talk was without a doubt an opportunity to remember. And thank you once again. And I would like to tell all the delegates, if I had met sir before 90s, I trust I would have taken hematology as my subject. And I don't regret taking rheumatology as a subject, but he's really known to all the teachers and all the faculty and all the students in Sion Hospital. We fondly call him MBA sir. We rarely call him as an MB Agarwal sir. And thank you, sir, that you have given me opportunity, and I will do my best to make this subject interesting and and create awareness and see that my students from at least from KJ Somaya have some passionate they're passionate about hematology. And once again, thank you so much, sir. And you had given me 5 to 7 minutes, and I've completed exactly in 7 minutes. Thank you, sir, so much for being so kind to me.
Thank you, Professor Niharika. Just goes to show how sincere you are in any work given to you. We have had number of personalities coming and inaugurating our webinars, but you were superb.
Thank you, sir. Thank you,
sir. The background work that you did and the survey that you talked about was an eye-opener. The only thing I can do now is that on behalf of Mumbai Hematology Group, I assure you, you invite us to teach your UG and PG.
Yes, definitely.
We are a strong force of almost about 200 people in the city of Mumbai, of whom about 30 are clinical hematologists, 40 to 50 are medical oncologists who can teach hemato-oncology, and a strong force of the laboratory medicine people. So they can create interest in this branch in your institution and in other teaching institution in the city. We thought that we are doing a lot, but I must tell you that your speech was an eye-opener. We should do something more and give us an opportunity, and we will come and teach them.
Thank you, sir. Thank you, sir. After the lockdown, definitely in 2021 or 2022, definitely,
of course,
sir.
Of course.
Thank you, sir. Thank you.
Thank you so much. And now I think it's time to begin with today's scientific agenda. And it's my pleasure to invite Dr. Eugenia Biguji to give her talk. You can share your screen and go ahead.
Yes, thank you very much. First of all, I would like to thank you for the kind invitation. It's a pleasure for me to discuss with you all this morning bleeding disorders in women. That is now, I'd say, a hot topic in the hemostasis scientific field. I think because we all realized how women have been neglected in the clinical practice for some time. And we are now trying to take care of them probably a little bit better. So my talk, this is the outline of my talk. I will first try to convince you how the bleeding severity in women is different from that present in men. Then we will talk a little bit about the prevalence incidence of bleeding disorders in women and how this is difficult and different in different countries. I will speak a little bit of specific disorders like hemophilia, von Willebrand disease, and rare bleeding disorders. and then something quite practical on how to manage menorrhagia and postpartum hemorrhage. So starting from bleeding severity in women compared to men, I want to share with you a clinical case that I had some time ago. This was a woman who had type 2 von Willebrand disease. She had quite a difficult pregnancy with a severe thrombocytopenia. In her life, she didn't have many bleeding disorders except for menorrhagia. And the two pregnancies she had, they were quite difficult to follow and to prevent postpartum hemorrhage. During the second pregnancy, she had a girl. She was diagnosed type 2B von Willebrand disease from the cord blood. And the father's comment was, better the disease in a girl. And he was thinking of football games. I was not happy at all. I would have preferred a boy, I must say, because I knew that in this girl, the future with menorrhagia and pregnancies were not going to be easy for her. So this is absolutely normal, because women, they have 2 more bleeding symptoms compared to men. If we have a look to the ISTH bleeding assessment tool score, of course, we have only 12 items for men and 2 more, so that these are 14 for women, because they also have menorrhagia and postpartum hemorrhage. So the score range is from 0 to 48 for men and from 0 to 56 for women. So of course, if we have the same disease, let's say type 3 von Willebrand disease, I expect to have a bleeding phenotype that is more severe in women. So let's focus on these 2 symptoms. First, on menorrhagia. This is the score we can give that goes from 0 to 4. And we have to tackle a problem when we assess these symptoms. We ask the women how they consider their menses. And of course, the self-estimation can be different. So how much is too much? And some women who come from a family where probably a bleeding disorder was present even in previous generation can be more resilient, and they can adapt their lifestyle and possibly diet to heavy menses. So I think this is one of the difficulties in evaluating the history of menses. Also, if you see the score to which we gave 2 points, we have here missed work school more than twice per year. And of course, again, this is not necessarily due to heavy menses, can be due, for example, to pain. Also, in the clinical practice, we have a score of 3 if we give, or 2, if we give hormone therapy together or not with antifibrinolytic therapy. But again, hormone therapy can be given not only for heavy menses, but also for anticonceptional purposes. So you can see that the score cannot give us an exact picture of the situation. The same, this is something I want to share with you. In the 1 point score, we have that we can give a point of 1 if the pictorial chart is more than 100. So what is the pictorial chart? The pictorial chart is a visual tool to assess more or less in quantitative way the menses, and you show to the woman this chart, and they have to say if they have light, moderate, or heavy menses. This is if they use the pad. This is if they use the tampons. You put the number collected in a day. You multiply for a factor, and you have a total number. I can assure you, because I use this every day in our clinic, that having a PBAC of more than 100 is really very, very frequent. So I think that this is a 1-point score, but you will give it to probably at least half of the women in your clinic. Also, the collection of this PBAC score is not an easy task. In my experience, if I just ask the number of the pad or the tampons used by a woman during the day, I can be answered with a number that is not realistic. So I have to guide the woman that is undergoing the interview by going through the day, and this is quite time consuming. Nevertheless, we use it in our clinic because we think that it's otherwise quite difficult to quantify the menses. This was first proposed in the 90s. The cutoff of 100, that I think is quite low in our, for example, in our country, gave a specificity and sensitivity of 80%. Of course, if you change the cutoff, the sensitivity and specificity of this tool will change. So, for example, in another paper in 1995, the cutoff was 185, and of course, the negative and positive predictive value were higher. Some women now like to use a mobile phone application because they are young. If they want to use the application, I encourage them to use, so they can fill in the chart at home, and I can review with them the score at following visits, especially to evaluate how our therapies are working for them. Moving now to postpartum hemorrhage. This is again the score we have to fill in when we assess the history of the women. Again, I think it's not easy to be collected. For example, 2 points are given if tranexamic acid is used during delivery. But for example, women are not always aware if tranexamic acid was used for them or not, and this is often not reported in the discharge letter. And sometimes, more recently, tranexamic acid can be used to prevent postpartum hemorrhage, independently of a bleeding disorder, because it was shown in the woman study that tranexamic acid is effective in all women. Finally, this score does not make a distinction between first and second postpartum hemorrhage, except probably in the 0.1 score, because it says lochia lasting longer than 6 weeks. So this is a secondary postpartum hemorrhage that is quite distinctive of women with bleeding disorders. The overall, I think the ISTH-BAT score is very useful. Nevertheless, in the collection of these two items, of course, we can have some problems because we don't have all the information, or these can be difficult to be collected. This is something that we must be aware of. Nevertheless, we use this score routinely in our clinic, and we find it really useful, especially to compare the evaluation between different doctors. Also, in the evaluation of these two symptoms, we must be aware that, of course, bleeding disorders can be a cause of menorrhagia and postpartum hemorrhage, but other causes can be present and must be evaluated and possibly excluded, especially when we first evaluate a woman that comes to us in the suspect of a bleeding disorders. Just coming to the conclusion of these two symptoms, they are not specific of bleeding disorders, as I said. We must explore other possible causes of menorrhagia, especially if we are hypothesizing a mild disorder, and also if only these symptoms are present, I'd say. During the time that a woman is coming to our attention, it is possible that we have to reevaluate possible causes of these symptoms. For example, if menorrhagia is getting worse with age in a woman, I have to think about uterine myomas that develop later in life. And also I must think that acute primary postpartum hemorrhage is always naturally, physiologically prevented by an effective uterine contraction. So often this symptoms is not necessarily present in mild bleeding disorders, while secondary postpartum hemorrhage, that means later from the second day on, is quite distinctive. So it must be asked if this symptoms was present or not. So moving to the second part of my talk, I want to discuss with you prevalence and incidence and how these are influenced by cultural differences, by selection bias in diagnosis, and country resources. This data come from the last World Federation of Hemophilia Congress. They show us how in the last 20 years we made a big advance in the diagnosis of all bleeding disorders. More or less, the diagnoses were triplicated, not only for hemophilia, but also for von Willebrand disease and other bleeding disorders, even more. Overall, more diagnoses are made, and this is for sure an advancement in our field. But of course, the country income influences the distribution of the severity. So only rich countries diagnose mild bleeding disorders. The diagnostic problems we can encounter is, on one hand, poor knowledge of bleeding disorders by probably general practitioners. And this is something that happens quite a lot in Italy, I must say. As I said in my presentation, hemostasis is quite a hated subject because it's quite complicated. So it's difficult for a general practitioner to know all the bleeding disorders. Sometimes there is some confusion about even thrombophiliac problems and bleeding problems. So this is one of the problems we encounter. Some diagnoses need quite an advanced laboratory tool. So for example, platelet disorders are not easily diagnosed in every lab. In case especially of mild bleeding disorders, patients can be resilient and so come to our attention only late in life. And it is not the case of Italy because we have a national health system, but private health systems can influence the availability of tests and therefore diagnosis. So severe and moderate bleeding disorders are nowadays quite easily diagnosed, I'd say, but mild bleeding disorders for sure are underdiagnosed. And of course, there can be a philosophical even debate on the issue if we really need to make a diagnosis if the bleeding disorder is very mild. But we will discuss later how this can impact the quality of life of patients, especially in women. So the distribution of bleeding disorders in women depend on the country income and availability of lab tests. Also on the country culture, because only in some countries prenatal diagnosis is available. And of course, this can be associated with the pregnancy termination. For example, for autosomal recessive disorders like type 3 von Willebrand disease or severe rare bleeding disorders. Also, country culture is important in terms of consanguineous marriages that are associated with severe bleeding disorders and that have an autosomal recessive inheritance, like a factor 7, severe deficiency, but also factor 5, factor 13, or fibrinogen deficiency, or also some platelet disorders like Glanzmann thromboasthenia or Bernard-Soulier syndromes. So moving to the third chapter of my talk, let's discuss a little bit more specifically some diseases, starting from hemophilia. And hemophilia, I think, is the big bias in our field because, of course, we think in terms of hemophilia and male sex because of course, the vast majority of hemophiliacs are males. And also hemophilia is the disease that is easier to diagnose because severe hemophilia, both A and B, is the most frequent severe bleeding disorder. For example, in our center, we have 200 severe hemophiliacs and only 20 type 3 von Willebrand disease patients. And so the vast majority of patients are males, but we will discuss problems with hemophilia carrier with low factor 8 or factor 9 levels, and how we have to consider also women in terms of mothers and sisters of our hemophiliacs male patients. So this is a paper that is already quite old. It was published in 2008 on Blood by Plug et al. And they evaluated almost 300 of hemophilia carriers. They had hemophilia factor 8 and factor 9 levels in 225 and almost 300 proven non-carriers. And you can see here regarding the characteristic of menses that they have an increased risk of anemia and need of iron supplementation, and also of restrictions in daily life. And this is present also with a mild reduction of levels, of clotting levels, between 40 and 60%. So we have to bear in our mind that even a hemophilia carrier with a level that is not so low, so who probably did not have big problems in previous surgeries, like, for example, small surgeries, not high risk of bleeding surgeries, they can have a problem in their menses and becoming anemic or also have a poor quality of life. So what I try to do in my daily practice is to remember to measure factor 8 and 9, not only in the patient that I see when they come for a new diagnosis, but also, so not only in the proband, but also in the carriers of the mother, because after the diagnosis is made, the mother is very focused on the baby, and it's quite easy to forget to evaluate also the carrier and her symptoms. So the first time we make a diagnosis, a new diagnosis of a hemophilia patient, let's try to remember to evaluate the mother as well. And if the carrier has low levels, offer the same level of care of a male hemophiliac, plus, and this is the most important thing, a gynecologist evaluation, because sometimes women never even thought that their menses were too heavy or that they can be supported in a gynecology clinic. For obligatory carriers, so daughters of our hemophiliac patients, we must remember to offer a measurement of factor 8 or factor 9 at puberty, so to be aware if they are at risk of heavy menses, and offer also genetic counseling. And here we have a discussion in Europe if it's better to offer genetic counseling at puberty or later on when they become of legal age. My personal view is that puberty is a good moment to offer also genetic counseling, because early pregnancy can happen before they become of legal age. It's important that these girls are aware of the transmission, of how the disease is transmitted, and so they're aware of what can be offered in terms of prenatal diagnosis and so on. Of course, this can be done in steps, not everything at puberty, but at least the puberty is a good moment to stop and focus our attention on the woman that the girl is becoming. So now I will share with you a case of a woman who was born in 1977. So she is now more or less in her 50s. She didn't have a family history of hemophilia, and this, I remember you, happens in 30% of cases. She bled and had and needed a blood transfusion after tonsillectomy when she was 7 years old, and she was diagnosed quite early as a mild hemophilia A carrier, but her factor A level was really low, 8%. This is not, this does not happen often. This is really quite a low level for a woman. This is due to an imbalance in the inactivation of chromosome X. And at menarche, this woman, and during young age, she had a heavy menorrhagia with anemia. She had problems of hemorrhagic corpus luteum on at least 2 occasions, and finally she was given estropogestenic pill. At 33 years, so not so young, she had a desire to become pregnant. In Italy nowadays, women tend to postpone their pregnancy in their 30s. So it's not even easy to become pregnant, we know, at this age, but this is our situation now. And in the case of this woman, she was diagnosed an infertility due to abdominal synechiae and fallopian tube closures. Plus, we had the husband who had a low fertility. So finally, at the age of 38, she became pregnant because of an egg donation and in vitro fertilization. This procedure is not allowed in Italy now at this time. So she went to Spain to undergo this procedure. But she came back, of course, pregnant, and we followed her through pregnancy. She had blood loss during the 3rd trimester, for a partial placenta detachment, and we had to treat her with a factor VIII concentrate for almost a month. And finally, the pregnancy was successful. She had a cesarean section for podalic presentation. We used prophylaxis with recombinant factor VIII concentrate. And even if the levels were more than 80% at delivery, the blood loss was not small, but this is a cesarean section, so it's still normal. But she needed a revision of the uterine cavity for rebleeding after 1 hour. There was no evidence of retaining the placenta. So you see that when factor VIII levels are really low, and we have a few cases, pregnancy can be a challenge. Going then to discuss von Willebrand disease, this is the first family that Dr. von Willebrand described in the Åland Islands, the Foglo family. She described a young girl who died at the age of 13 of menorrhagia, and as you can see in the family tree, other brothers and sisters were affected, and some of them died at young age. We now know that they were affected by type 3 von Willebrand disease in a severe form for sure. What I want to discuss with you now is the menorrhagic symptoms in patients affected by type 3. This is a very recent paper that was published in 2020. It's the 3 Winters study that collected a large number of patients affected by type 3 severe von Willebrand disease from Europe and from Iran, where this disease is more common due to consanguineous marriages. So we have this large group that was never possible to describe before. And what I think was really interesting was a comparison with a previous large European study that evaluated patients with type 1 von Willebrand disease. So levels are quite different in these 2 groups. But if we consider the ratio between so here is the type 3 patients, and you can see that menorrhagia is present in 61% of the women. But if we compare the ratio of type 3 and type 1 patients with menorrhagia, you can see that the ratio is 1, and this means that the menorrhagia is present in an equal number of patients with type 3 and type 1 von Willebrand disease. So I put here a cause or an effect because, of course, the problem here is the selection of patients that come to our attention. Young women with menorrhagia are sent to our clinic because of this symptom, and we screen them for von Willebrand disease. And this is why we probably have a large number of patients with type 1 von Willebrand disease affected by menorrhagia. This is, I think, very nicely shown in a very well-described cohort from Ireland. This is the LOVIC study, and LOVIC stands for low levels of von Willebrand factor in Ireland cohort. So here we have almost 300 patients with low levels of von Willebrand factor, meaning between 30 and 50%, measured on 2 separate occasions, at least 3 months apart, and with a significant personal history of bleeding. And as you can see, almost 80% are women. And when they were followed for 3 years, this is the LOVIC study, blood group 0 was present in 90%. So you can see that this cohort is enriched in women and type 0. they are only women after menarche. And in this group, you can see that these are the menorrhagic symptoms are really quite high. And I think this is due to a selection bias because we screened them for von Willebrand levels because they came to us for menorrhagia. So these data do not surprise me. And this is also very interesting. This is the score given for menorrhagia in the study. And you can see that women with levels between 40 and 50 and women with levels between 30 and 40, they're not so different in terms of high score for menorrhagia. So let's now discuss what is the quality of life in women with von Willebrand disease and heavy menses. These are the results from a study published by Govorov in 2016. This is quite recent. And I want to stress out that these data were collected in Sweden. This is very important in my mind because I think that quality of life is correlated and is influenced by the cultural background of women. So resiliency to menorrhagia can be quite different in a country where women go to work every day, or probably another country where women work less frequently. And also resiliency to menorrhagia, I think, is quite influenced by the cultural background. This study selected a small number of women, as you can say, only 30. They were selected from a local registry. The enrollment in the registry is voluntary. And in this paper, the rate of enrollment is not reported. The study was offered to all patients, but we do not know how many women were accepted to participate. And of course, these are all possible causes of selection bias. But what is striking is that even if 80% of women received some treatment for heavy menses, only less than 50% of them considered this treatment effective. And this is something that I think we must consider in our practice. Also, this graph shows how daily life practices were influenced by the menorrhagia. So you see that more than 60% of women enrolled in this study said that menorrhagia affected their vacations, their family life, and so on. So from this study, even if I think it was biased by the selection in the enrollment of women, so probably only the women that were interested in this problem responded, nevertheless, we must bear in mind that this is a problem in our patients. And here I want to share with you another clinical case. This woman was more recently born. She was born in 2006. She had a clinically relevant menorrhagia after menarche. Menses lasted more than 10 days. Regarding other symptoms, she did not have any. She didn't have a family history of hemophilia or bleeding disorders. A maternal aunt had a history of menorrhagia, and the father had a bleeding after tonsillectomy and ankle swelling after trauma. We evaluated this young woman. PT and APTT were slightly prolonged. As you can see, factor 7 and factor 9 were really slightly reduced, even after vitamin K administration. genetic for factor IX was carried out, and there was a missense mutation described in mild hemophilia B. This was also present in the father, who has nevertheless a higher level of factor IX compared to the woman. We also did an evaluation of the methylation of chromosome X in our patient, and this was not different in the two chromosomes X. So this is not a classical case of low levels factor IX in a woman. Also, her levels of factor VIII and von Willebrand factor were not stellar, I'd say. She has a positive blood group, and she has a von Willebrand factor that is around 50%, I'd say. Also, platelet function showed a mild aggregation deficiency with low concentration agonists. So basically, she does not have only one clear bleeding disorder. She has three different things that are mildly impaired, but she has a symptom that is clinically significant. This is menorrhagia. She received genetic counseling because of the factor IX missense mutation. She has a mild higher risk of bleeding in case of surgeries that we will deal with tranexamic acid and possibly DDAVP in case of high-risk surgeries. Nevertheless, the problem in this young woman is menorrhagia. We have to treat this, and we will do in the next months and see if we can give her a better quality of life. I wanted to focus now on rare bleeding disorders, especially with the two of them that are associated with recurrent miscarriage. And these two are severe factor XIII deficiency and afibrinogenemia. As I said before, the prevalence and incidence of these diseases are correlated with consanguineous marriages. So their incidence is higher in countries like Iran, where this practice is more frequent compared, for example, to Italy. For factor XIII and afibrinogenemia, I think it's very important to offer nowadays prophylaxis during pregnancy. There are some guidelines available. So, for example, for afibrinogenemia, the guideline is to begin replacement therapy at 4 or 5 weeks of gestation. And the target fibrinogen levels are between 50 and 100. If previous pregnancies were not successful, we can increase these trough levels and peak. And during labor, we need higher levels, of course, and we must monitor these women very carefully because, as I said before, postpartum hemorrhage can have other causes. But of course, if you start your labor with 200 milligrams of fibrinogen, you are at risk of postpartum hemorrhage since physiological levels are 400 more or less. What I try to do in these women is to bring them at delivery with a very good level of hemoglobin, at least 12 grams per deciliter, because I think this is really effective in preventing postpartum hemorrhage. For severe factor XIII deficiency, again, we want to begin the replacement therapy as soon as possible. These are the possible choices we have. Fresh frozen plasma, cryoprecipitate, plasma-derived factor XIII, or a recombinant subunit A Novo13. We want to target levels of at least 2-3% at trough levels. And since the half-life of factor 13 is quite long. We just boost at labor with a 1000 unit. Postpartum, it's not generally necessary any more treatment since, as I said, factor 13 has a longer half-life. So here I want to share with you a very recent case that we are following. It's the case of a young woman. She's now 15. She's the daughter of first cousins. She had a first major bleeding from the oral cavity at the age of 18 months in Egypt. She was diagnosed a severe factor V deficiency at 4 years. And she had a few treatments with fresh frozen plasma before puberty. Then she was referred to our center a couple of years ago after 3 hospitalizations for menorrhagia and hemorrhagic corpus luteum, despite progestinic pill. And I must say that here the problem was a cultural problem of explaining to the family the real need of the pill, not for anticonceptional purposes, but to prevent the bleeding, the menses bleeding, but also the ovarian bleeding that is, I think, something we must prevent in these women. Last year, she had a severe post-traumatic muscular major bleeding, and she received more than 10 fresh frozen plasma infusions with the development of an anti-factor V inhibitor. And this was associated with the worsening of the bleeding phenotype. So she had 3 episodes of hematuria, and she needed to be treated with platelet concentrates that work very well, even in the presence of an inhibitor, because the platelets have absorbed factor V from the plasma, but they can deliver factor V where it is needed without being inactivated by the antibody. So my comment here is platelet transfusion is highly effective in severe factor V deficiency with or without inhibitor, but we must consider the risk of antiplatelets antibodies that can be associated to the use of platelet pools, and so must be weighted against the risk of exposure to a high number of fresh frozen plasma transfusion. I just had last week an important news about this young woman, because we checked the inhibitor level, and after 3 months she completely cleared the inhibitor. So this is good news. Of course, we have to re-expose the woman to fresh frozen plasma, but we should be able to do it at least for 2 or 3 treatments if needed. For her, it was very important to spend quite a lot of time explaining to her and the family the importance of the pill to prevent menorrhagia and ovarian bleeding. And now she is on continuous estroprogestinic pill without any problem. She will interrupt the pill when the spotting will present. So it should happen 3 or 4 times a year. Finally, I want to share with you what is the women's voice. This is another very recent paper that is a qualitative study that was carried out in a small number of Canadian women affected by different diseases. And again, I want to stress how these studies must be done in different countries, because of course they reflect our cultural differences. But it is interesting to listen to what they tell us. And first of all, they say that there is not a clear differentiation between normal and abnormal bleeding, in their opinion. And also, the label of carrier does not reflect probably their real problems, and can be considered as dismissive. And also hemophilia carers, they only share the experiences of their male relatives. So hemophilia is known through the experiences of effective male more than through the experience of hemophilia carriers, women who are women. So what I do, and this paper made me think about my clinical practice more, is that I have to use some time, to dedicate some time to explain bleeding symptoms can be present also in the normal population. So this is not necessarily easy to make a clear distinction because there isn't. I need to focus on educate my patients and also carriers, recognize the symptoms and treat them early in the presence of a bleeding, and also the problem of quality of life, as I said before. About the problem of putting a label, of course, we must not be dismissive with hemophilia carriers, but this is something that I think that now in our field we are all recognizing. And this is why you invited me to speak today about bleeding disorders in women. Of course, also I want to stress out that the difference is, there is a big difference between women coming from a family where hemophilia is known to be present, or those women who come from families where hemophilia is not known. So they will know about it because they have probably a baby who is affected. So it's not easy to compare these two situations. Finally, just because the time is flying, how do we tackle menorrhagia and postpartum hemorrhage? This is a report published last year from Bangal et al. And basically, this is a survey in Europe about 140 more or less hemophilia centers. As you said, the response rate of the survey is not high. Nevertheless, less than 50% of the hemophilia centers offer a joint clinic with the obstetricians or gynecologists. And these are the causes they point out. So institutional barriers, and we have to fight this problem, or financial barriers, that is probably more of a problem, and so on. What do we do in our clinic? First of all, we must bear in mind that any therapy for heavy menses must be really tailored on the patient. There is not one recipe that is good for all. So we really have to focus on the patient. The second point is, unfortunately, one appointment and one evaluation is not enough. We need to monitor our therapies in time and change them if necessary. If you remember the Swedish study that I showed you before, only not even 50% of the women who received the treatment for menorrhagia were happy about the result. So we need really to find the right therapy for our patients. And finally, as I said, we work in a team. So the gynecologist is part of the team, the hematologist is another part, but we also need a support that can be quite different in different situations, can be offered by other peers, by nurses, by psychologists, but we have to deal also with the psychological needs of our patients and try to support them as much as we can. This is the flow chart we follow when we offer our therapy. First of all, support with an iron therapy must be offered to everyone. Some women do not really realize how levels of hemoglobin can change their quality of life. Then we have to discuss with the woman if a pregnancy is desired now or in the future, and when. If a pregnancy is desired now, we offer genetic counseling, and we evaluate if a prophylaxis is needed during menses while she waits to become pregnant, or continues to avoid the hemorrhagic corpus luteum. If a pregnancy is not desired, but is desired in the future, the pill or the estroprogestinic or the only progestinic or the intrauterine device can be offered depending on the woman. And if the woman is more advanced in life and she does not probably had already some children, does not desire any more pregnancies, and has a very difficult life due to heavy menses, probably because not only there is also a local problem like myomas and so on, we must consider endometrial ablation or hysterectomy. Even if I must stress out that I'd like not to see hysterectomy performed before the age of 50, in my experience. So before pregnancy, we offer counseling about the disease transmission, about the pregnancy risk, the risk of miscarriage and the risk of bleeding, on how we can tackle the delivery, the puerperium, and the neonate risk. That is the only real question that the future mother will ask you, but nevertheless, we must offer information on all of these issues. What I try to do is, since many women come to me only where they are already pregnant, is try to remember at annual visit that this is something we can offer them, and this is important to do it. I want to share with you these two qualitative research papers carried out in South Africa about the genetic counseling in hemophilia, because they made me think and rethink about my daily practice in Milano. Basically, what they discovered is that the understanding of genetic causes and transmission of hemophilia was very limited in South Africa. These were studies carried out in quite poor areas of the country. And so the language spoken by the women did not have even the words describing the genetic transmission. And even if the situation can seem quite different in Italy, I can assure you that in my clinical practice, I also encountered quite a number of situations where I had to explain again and again how hemophilia or von Willebrand disease is transmitted, because this was not clear. And we think it is clear because we explain it when we make a diagnosis, but we must consider that these patients are flooded with information at diagnosis, and probably not all of them are really understood. And so the genetic counseling must really be offered, possibly before a pregnancy, to review all these informations. And this flow chart was published in Blood last year by the Dutch group. And basically, it reminds what can be offered during genetic counseling in terms of ultrasound, amniocentesis, or non-invasive diagnosis in terms of finding the Y chromosome on the maternal plasma. Then if it's positive, we can go on and offer chorionic villus sampling and so on. Of course, as I said before, the cultural background will influence a lot the acceptance of different offers, and this is something that is important to offer, probably possibly before the pregnancy is started. Regarding the type of delivery, There is a lot of discussion nowadays. The US guidelines, in case of this is in case of a supposed hemophiliac patient, they give the guideline to offer a cesarean section. The UK guidelines to discuss this with the family. In the Netherlands, a vaginal delivery is offered because an urgent cesarean section can be performed between 30 minutes. Again, I think the problem is how old is the woman, if other pregnancies are desired, and so on. So this is something that must be also tailored on the patient. Regarding type 3 von Willebrand disease and pregnancy, some systematic review were carried out in the last 2 years. We don't have a lot of data, but for sure we know that these patients have an increased risk of a primary postpartum and secondary postpartum hemorrhage. Again, this is another systematic view about the strategies in relation to maternal and neonatal bleeding. As you can see, the most striking, I think, information is that secondary PPH is quite high. This is quite easy to be prevented. So I think this is something we must focus on. Regarding primary PPH, other factors can come in and it's more difficult to be evaluated, I think, in my opinion. Again, for delivery, we work in a team, and what we do with a pragmatic approach, at the 3rd trimester, we meet with all the team and we decide what strategy we want to offer to the woman, if a vaginal or cesarean section. We write down very clearly that we advise against the prolonged 2nd stage labor, against the use of vacuum or forceps. We give an advice if anesthesia must be given, which kind we can offer. If a concentrate is needed, we already give advice for the amount of concentrate. And we also bring the concentrate to the delivery room so that when the labor starts, we are ready with everything that is needed. We write a report and we share this not only within the team, but also with the patient that must be informed. And as I said, we deliver the concentrate to the delivery room. More specific point for delivery, especially epidural anesthesia. It's generally accepted that normal levels of the deficient factor, that means more than 50%, is sufficient to normalize the risk of a spinal or epidural hematoma to the risk of the general population. But in the UK guidelines, neural axial anesthesia is not recommended in type 2 or type 3 von Willebrand disease, irrespective of von Willebrand factor activity. So this is something that will probably be changed in the next guidelines, but we don't, at the moment, I wanted to share with you this caveat. In our practice, we are quite keen on the use of tranexamic acid because it was shown that this is effective also in normal women without bleeding disorders, and for sure we think that it works also in our women. The big issue now is, nevertheless, how much is enough? So how much we must give in terms of levels of missing factor to our women. And this is because in a Dutch study published almost 5 years ago, they saw that almost more than 30% of women of hemophilia carriers or women affected by von Willebrand disease presented postpartum hemorrhage, and almost 10% of them had severe postpartum hemorrhage. And I think one of the problems of this paper was that there was no clear evidence. There was no evaluation if the woman knew that she was a carrier or not. So all carriers were considered together, while I think there must be made a difference between those who know to be carriers and those who do not, because in those we cannot prevent the hemorrhage until we know that they are carriers. So the big discussion now, is the threshold of 50% enough? We know that in healthy pregnant women, factor VIII levels are around 200% in the third trimester. So probably 50 is not so high, especially if, as I said, the uterine contraction is not enough. Of course, those women that have probably 60% of factor VIII, if they start bleeding because the contraction of the uterus is not so strong, they can lose more blood compared to women who have 200% of factor VIII. So about the neonatal care, we generally collect the cord blood for diagnosis if it is possible, and we give advice against the use of intramuscular injection and venipuncture, and caution with heel sticks. As I said, we are very keen on preventing secondary postpartum hemorrhage. So we ask the women to be in touch with the center for the days after the delivery. And here is my last slide, is the future in my personal hopes. I hope that specific care is given to women to identify and treat their bleeding disorders. Joint clinics should be offered together with gynecologists and obstetricians, and genetic counseling should really be given to all of them. And this, of course, need to be based on specific research in terms of education, quality of life, and qualitative research that must be country-specific, about the best therapy for menorrhagia, best therapy for postpartum prevention, and the role of clotting factors in placenta development. And I thank you for your attention.
Thank you so much, Dr. Eugenia. That was a wonderful, complete coverage of the subject. And you made it so simple, I think even an undergraduate student would have followed everything. We learned a lot from this talk. We have the Indian faculty who would like to discuss their difficulties with you. And just before we do that, we will just get over the answer to that quiz that was put to the participants. So I'll just share my screen and show them the answer, and then we'll come back to the discussions. So regarding the quiz, you were shown a picture with gum hypertrophy. You were told that this is a case of acute leukemia, treated, day 14, patient had severe pain in the pelvic and the long bones, and then an MRI was done and a bone marrow examination was done. You were shown the picture of the pelvic bone, the upper femur, the long bones MRI, and another picture of long bone of the MRI. And then you were shown the bone marrow biopsy, and you were asked a question what the diagnosis is. So all those arrows in the MRI indicated areas of increased bone marrow liquid. All these areas wherever you are seeing this blackiness. And the biopsy had shown severe coagulative marrow necrosis. And there were some ghost cells here and there. So this was bone marrow necrosis. We have received 36 people's reply who have tried to answer, of which 10 are the correct answers. I'll just enumerate those 10 people whose answers are correct. Dr. Akshay Lahoti, Dr. Abhishek Sharma, Dr. N.D. Tang, Dr. Naved Tamboli, Dr. Thanuja Desanaike, Dr. David V, Dr. Gunjan Prasad, Dr. Ganju, Dr. Paresh Dave, and Dr. Dinusha Chaturani. Out of U10, the quickest answer was Dr. Dinusha Chaturani. So congratulations to Dr. Dinusha Chaturani. From the name, I understand that she's from Sri Lanka. And I must compliment the Sri Lankans getting the correct answers repeatedly, it just goes to tell that how the Sri Lankan College of Hematologists methodical teaching, etc. is. So congratulations, Dr. Dhinuja, and we will send you your prize. So that's about the quiz. And now we come to our discussants who will be asking questions to our speaker, Dr. Eugenia. We start with Dr. Srimati Shetty.
Yeah, thanks, sir. Hi, Eugenia. It was a great talk. And it's always nice to see people from Angelo Bianchi, because you may not be aware of it. I got trained in Angelo Bianchi Center along with Flora. Both of us were Professor Manusi's students. Anyway, coming back to the question, my question was on the strategy to screen menorrhagia and BPH. You have given a full description. I mean, I don't need an answer now. That was much more than an answer. Now, coming to an extension of the same question, most of these cases are mild cases. We may miss them in the initial screening assays. So can we have a cost-effective set of investigations with the highest sensitivity and specificity?
Thank you for the question. It is very interesting. I would say two things. We need, as I showed, I think that the Irish cohort showed very clearly that we can have a selection bias if we analyze patients, because they come to us because they have menorrhagia. We will find quite a large number of low levels of von Willebrand factor patients. And the problem is, do we need to make this diagnosis or not? Does it change something in our clinical practice? Especially if we have a limited amount of resources. How does this diagnosis change my practice, my offer in terms of finding a solution? And what I would say is, if I don't have resources, if the only symptom is menorrhagia, I will focus on the symptom and try to give the best treatment for the symptom, because it does not change with the diagnosis. My treatment will be the pill, the best pill I can find for that woman with those levels. Then I offer, while I find the pill, I will offer tranexamic acid, a very good iron Marshall supply, because I want these women to be with normal levels of hemoglobin. I don't want them to be anemic. So I will treat the symptoms. And of course, if I have the resources, I can offer also the measurement of von Willebrand factor. I would like to offer also the screening of platelet function, because we cannot distinguish on the symptom a platelet dysfunction from a low von Willebrand factor level. And of course, it is easier for us in the lab to measure now von Willebrand factor rather than evaluating platelet function, especially because if the woman is anemic, then all the easy tests for platelet function, like PFA 100, they will be influenced by the anemic levels. That's why it is much easier to offer an evaluation of von Willebrand factor. So if I had all the unlimited resources in the world, I would offer both a screening of von Willebrand factor and platelet function. If I don't have any resources, I will just go for treating the symptom, that I think it's the most important thing to do in these women. And of course, if they are menorrhagic, and if they have low levels of von Willebrand factor or a mild platelet dysfunction, I will offer them tranexamic acid with or without DDAVP in following risk maneuvers like surgeries or tooth avulsion, something like that. But I focus mainly on the symptom, I must say.
Thank you.
Thank you. Dr. Chandrakala.
Thank you, Eugenia. It was a very wonderful presentation. We have quite a few female VWD patients, type 3. And usually their main problem is preconception counseling. Because they come with recurrent corpus hemorrhagic cyst. Whether the fertility is same, can they get married, are we having children, and during the pregnancy, prophylaxis with the factors. We have managed about 5 pregnancies till now, but we have not given prophylaxis. But what is the role of giving prophylaxis during the pregnancy, and what is the fertility rate in these patients?
Okay, we have only, as I said, few patients with von Willebrand disease in Italy. In our center, historically, we had only 5 patients. We are now having more and more because we have immigrants from countries where consanguineous marriage is normal. So we are having more now. So I don't have a lot of experiences with old women who had a lot of pregnancies. What I can tell you is that even von Willebrand disease type 3 has quite a heterogeneous phenotype. So we have patients with less than 5% of factor VIII, and I think that the main problem is the factor VIII level. I cannot demonstrate this because numbers are very small, but this is my feeling, that factor VIII levels are the most important thing, even in women with von Willebrand disease type 3. So those we have with very low levels, less than 3%, let's say, those women, especially in the past, where only cryoprecipitate was available, they had problems in conceiving because they had many problems of corpus luteus hemorrhagic corpus luteus in the past. So their fertility is quite low, I'd say. If we can think that we can prevent these kind of problems in the future by giving the estroprogestinic pills at puberty and carrying it on for all the time necessary until they desire a pregnancy, I think that we can preserve their fertility. Then we have those patients who have 4 or 5% or even 6 or 7 of factor VIII. And those women, we have 3 of them, they conceived and had a non-eventful pregnancy. So we were quite happy. We had to make quite a careful plan for the delivery, but we did not have any problems. Regarding possible bleeding during pregnancy, we had one woman with type 3 von Willebrand disease, but she has really a very severe bleeding phenotype, as I said. In that patient, we had a placental bleeding during pregnancy, and we offered prophylaxis for 2 months, so not the whole 9 months, but only for a period. And we are now following quite carefully even patients with type 2A or 2B pregnancies. And we had a couple of patients with a placental detachment in the first trimester. And in that case, we offered prophylaxis, and we saw, because we always, first of all, we say, please stay at rest at home. We give Progefix as a progestinic to help the placenta to reattach. But if we don't see a better situation in 2 weeks, we start a prophylaxis with the von Willebrand and factor VIII concentrate. And we had now 3 or 4 cases that we followed through and went quite well, I must say. So we follow the first trimester quite carefully, especially if they say they have some bleeding. And we offer prophylaxis in these cases.
Thank you. Thank you.
Thank you. Dr. Ankit Rayani.
Thank you, sir. Dr. Belushi, thank you so much for the comprehensive overview on the bleeding disorder in women. You covered all of the inherited disorders. So let me just take a liberty and ask about acquired bleeding disorder that we see in routine practice. So my question is regarding thrombocytopenia in pregnant women. So how do you investigate? What is your treatment, the algorithm of investigation, and how would you minimize the invasive investigations like bone marrow investigation, and how would you work around that?
Okay, so you're asking me about acquired thrombocytopenia in pregnancy. Generally, we know that from the second trimester and especially in the third trimester, we can have a mild thrombocytopenia due to volume increase and plasma volume increase. So basically, what we try to do is if platelets are more than 100,000 per ml, we don't do very much, I must tell you. If the platelets go below this level, what we do always is we collect the history of the patient quite carefully, trying to understand if an autoimmune disorder like especially lupus is the one that we are most worried about, is present in a probably smoldering form, I'd say. And we always exclude lupus anticoagulant in these patients because, of course, the treatment is completely different. So what we do for sure is an exclusion of lupus anticoagulant. And then we tend to postpone, if the thrombocytopenia is not severe, so let's say between 80,000 platelets and 100 or 70, we tend to postpone all the diagnostic algorithm after pregnancy because we think that this number is not going to increase a lot. The risk of postpartum hemorrhage does not need really a treatment. We can postpone it, and it's not easy to evaluate a woman during pregnancy. That's what we do. If the levels is below 70, then we start I would say a usual ITP algorithm, knowing that if platelets go below 50,000, we must start probably prednisone, but we will reevaluate the woman after the delivery because it's not easy to exclude everything during the pregnancy. It also depends when it starts, you know. If it's just in the last 2 months, it's easy to postpone all the things and just make a careful plan for the delivery, like, for example, avoiding epidural anesthesia or stuff like that. That's what we do in our practice.
Okay, thank you. Dr. Abhishek Dudatra.
Thank you, sir. Thank you, ma'am, for the very lucid and informative talk. All my questions regarding congenital bleeding disorders are already answered. So my question is also for immune thrombocytopenia during pregnancy. So what's your opinion on using TPO agonist in ITP during pregnancy? Are you using it in your clinical practice as a second line or third line agent?
Not for first diagnosed cases. There are women who are now on TPO mimetics during pregnancy and they carry it on. We don't have many data on that, of course, but if it was a second or third line treatment, we are not keen on stopping it. That's the problem. Okay. For sure, we do not begin this kind of therapy as a first line treatment during pregnancy. It hasn't happened yet. We are a bit, as I said, we try to postpone the beginning of new therapies during pregnancy. We use prednisone during pregnancy in most cases. We haven't been in the need of using a TPO mimetic during a pregnancy until now.
Thank you.
Thank you, Dr. Dheeraj.
Yeah, good afternoon, Dr. Eugenia. Excellent talk. I just wanted to ask one important question. Does age or various stages of menstrual cycle, OC pills alter the coagulation factor levels? Or is it very insignificant that we should not keep that in mind because the cutoffs are too low for diagnosing the bleeding disorders or coagulation disorders?
I'm not sure I got the question completely. The audio was a bit disturbed. So you are asking me if the levels of von Willebrand factor are associated with the severity of menorrhagia?
Sorry, I am asking whether age or menstrual cycles or OC pill use affect the coagulation factor levels, including von Willebrand factor.
Okay, so you're asking the age thing relating to the levels of von Willebrand factor, right? And the
even OC pills or hormonal changes during menstrual cycle, will they affect the levels? And should we keep that in mind when we are interpreting the results?
Yeah, I agree with you completely. Age influences the levels of von Willebrand factor, and the same is for the estroprogestinic pill. So what I really recommend is, if it is possible, measure the levels of, if you are interested in evaluating von Willebrand factor as a possible cause of menorrhagia, try to do it before you start the estroprogestinic pill, because after you have begun the pill, the levels will be higher. So you will probably not be able to diagnose a low level of von Willebrand factor. Of course, if you have a type 3 patient, you will see the levels will be, in any case, very, very low. But in those cases of low von Willebrand factor levels, you can miss a diagnosis if you measure the levels after you started the estroprogestinic pill, for sure. About the age, it would be wonderful to have age-related normal ranges, but this is really, I think, impossible in the clinical practice. What I do is, if I see a woman who is in her 50s and she is blood group type A, and I see 51 ristocetin cofactor level, I think this is a low level for sure, because at the age of 50, type group A, I would expect more. But even in our center, where we do a lot of research on these things, we are not able to have an age-related and blood-related normal range, because you would need to have very large numbers. I took the liberty, I spent last year in Leiden to do some research, and I analyzed levels of von Willebrand factor in the normal population. So I had the chance to evaluate how the increase of von Willebrand factor is associated with age and with blood group. I found out something that was quite new and interesting for me, that blood group no, so means blood group A and B, they increase their levels more than blood group A with with age, as if they can, I would say, increase their levels because the endothelium is I would say not activated, but let's say it's stressed, and probably blood pressure can increase the levels. This was quite interesting, but they had only the antigen levels. They didn't have the ristocetin cofactor, so I couldn't analyze that data as well. But for sure, I would expect that levels change with age and also with the pill.
Thank you.
Thank you, Dr. Dheeraj. Before we go to the second round, I'll just take up a couple of questions from the audience. Dr. Thanuja Disanaike from Sri Lanka wants to know, what is the mechanism of miscarriages in factor 13 deficiency and in fibrinogen disorders? Is it just the bleeding in embryo or anything else?
I think is the placenta development. That is mainly due to the mother's level of factor 13 or fibrinogen. We know that during the placenta development, the blood barrier changes a lot. And I think this is what makes miscarriages associated with these two specific deficiencies. It's quite interesting.
Thank you. She has another question. What is your experience in using anticoagulation management for primary and secondary VTE prophylaxis in a woman who is a bleeder?
I was quite lucky that I didn't have any woman with bleeding disorders who needed really to be anticoagulated for VTE prophylaxis. Our management is, first of all, avoid primary PPH by giving concentrate if necessary. We use a lot of tranexamic acid. We know now that the use of tranexamic acid does not increase the risk of VTE in the postpartum. This is a good thing. We have quite a lot of women who deliver at a, I'd say, advanced age for a woman to be delivering. That means in their late 30s. And in Italy, it is the guideline is to give VTE prophylaxis if you are more than 38 or more than 35 if you have a cesarean section. We never, in our women with bleeding disorders that are not necessarily mild, we do not use any VTE prophylaxis except for elastic stockings, because as I showed, a secondary PPH is the big problem in these women with bleeding disorders, and I don't think they need a VTE prophylaxis. We never had any VTE problem in our women, even if they deliver at quite an old age in Italy.
Thank you. So we'll come back to Dr. Srimati Shetty. You have
Yeah, hi, Eugenia, thanks. My second question to you is on dysfibrinogenemia. It's generally associated with thrombosis. Can it lead to bleeding, specifically during pregnancy? And second part of the question is, how do you diagnose dysfibrinogenemia if you don't have an ELISA system for finding the fibrinogen antigen? Reptilase time alone is sufficient, or all right?
Thank you for the question. I will start from the second part of the question. So how do you diagnose the dysfibrinogenemia if you don't have an antigen? It's very difficult. I can give you my experience. Many cases of dysfibrinogenemia have a normal prothrombin time, a difference with the hypofibrinogenemia. So if you find levels of fibrinogen that are less than 100 milligram per deciliter, and your prothrombin time is completely normal, I'd say that dysfibrinogenemia is more, you will probably, yes, you will probably have more chances of a dysfibrinogenemia than a hypofibrinogenemia. But of course, I don't have the numbers to demonstrate this. This is just my personal experience. Because we have the antigen, so I have this data, and I have now almost 10 cases like this. So it's quite a strong, I think, association. Regarding the association between dysfibrinogenemia and thrombotic problem, I don't think, and even this is my personal experience, I don't think there are that many cases of thrombotic problems in people, in women, or even men, who only have the dysfibrinogenemia and do not have other thrombophilic mutations. This is my personal experience. I think that, of course, we have a biased selection because those cases with dysfibrinogenemia and thrombotic problems were studied and evaluated because they are very interesting. But we also had a patient with dysfibrinogenemia who didn't have thrombotic problems and who had bleeding at delivery. So if I have a dysfibrinogenemia and I have less than 100% milligram per deciliter of fibrinogen, I will give fibrinogen concentrate at delivery because low levels of fibrinogen are really a risk factor for PPH.
Okay.
And tranexamic acid, of course. I use a lot of it.
Thank you, Dr. Srimati.
All right, thank you.
One more question from audience. Dr. Sithu Lin desires to know your preferred method of contraception in a woman with bleeding disorder.
Okay, so in Italy, as I said, we don't have many pregnancies, unfortunately. We are a country with this problem. So Mirena, the intrauterine device, that is very well described as effective and useful in women. It is a problem to be inserted if you have not delivered vaginally before. You need to do it with a very, I'd say, with an experienced doctor if the woman has not delivered before, and can be painful. So basically, what I try to do is, if I have a very young girl, we try to stick to progestinic for a while. If the progestinic is not enough, we switch to estroprogestinic pill, and we give it even in continuous if necessary. That means that you do not stop after 21 days, but you carry it on, and you only stop after every 3 or 4 months if there is a spotting. That is this is very effective. I used, as I showed in that young girl with the severe factor 5 deficiency and inhibitor, because you have less chances to bleed, and so this is very effective. If the woman has delivered and vaginally, Mirena is a good option, but it's not very much loved in Italy, I must say. It's different in the UK and in other northern countries where I know it's very much used, but in Italy, I always meet some kind of lack of happiness, let's say. So most of our women are on estroprogestinic.
Thank you. Dr. Chandrakala.
So we recently had a 4-year girl with a jaw pseudotumor, and it was actually, we gave her a prophylaxis with the intermediate purity factor, that is a VWF rich factor 8, and she did not respond, and she started bleeding. We had to do surgery, and we did an inhibitor. She came out to be VWF, antibodies to VWF. And it's an oral cavity surgery. It's a very vascular surgery. So patient of VWD with inhibitors, how do you manage for the routine bleeding, and how do you manage during surgery?
Okay. We had only one case in our center, and we managed her with a recombinant factor 8 concentrate during surgery, because there is no traces of because this patient of ours, she had anaphylactic reaction to the von Willebrand factor. So we really needed something that was completely pure and not without traces of von Willebrand factor. So recombinant factor 8 is a possibility, especially in case of surgery. I think now one possibility that is not enough for surgeries, but can avoid spontaneous bleeding that we had in this patient, and we are going to start it now, is to give emicizumab, because it gives you almost like 10% of factor 8. 10% of factor 8 in a woman or even a man who has von Willebrand, severe type 3 von Willebrand disease, is a lot of, I think it's going to be effective. The other thing that now can be, I hope it will become available, let's say, is the fitusiran, because in these patients, especially, for example, I was thinking to use fitusiran in our factor 5 deficient patients, because I think it can be an alternative choice, because it's very effective. Of course, the thrombotic risk can become higher, and we know that there were some cases of arterial and venous thrombosis in hemophiliac patients using fitusiran, but I think that in these disorders that do not have any future chances of getting a concentrate, it will become a possible choice in the future, of course, but I hope it will become available in 3 years or so.
Our patient also had a reaction with the VWF factor. So we did a surgery with the factor 8 along with the Novoseven. We had to give IVIG because the platelet count dropped to 10,000. So now we put her on emicizumab for the last 3 weeks because she was bleeding intermittently. So now she's doing well. So we also gave rituximab 100 milligram for about 4 weeks along with emicizumab. Her swelling has completely disappeared. So we are planning to continue for about 3 months.
Yeah, that's the other possibility that we thought for our patient with the factor V inhibitor. The problem is that now with the COVID situation, rituximab is a bit of a strong choice. Of course, if you don't have any other chances, we must use it, but I'm not so happy about it at the moment in Italy, for especially for in our case for a young girl who needs to go to school and everything, so she will be exposed somehow to the virus. If I can avoid it, I'm more happy, but I agree with you that it is a chance.
Thank you.
The problem is that rituximab will probably work for 6 months or a year, and then you have to treat her again. But of course, type 3 von Willebrand disease with inhibitor is a big problem. And I think that we haven't realized it yet, because, and the 3 Winter study is going to work on that issue as well. But these are so rare that even the inhibitors are rare.
Yeah, very rare. Thank you.
Thank you, Dr. Chandrakala. Before we go to Dr. Ankit, one more question from the audience. Dr. Meenakshi Mishra wants to know that all women with menorrhagia, where gynecologist has failed to find a cause, do you investigate thoroughly for a bleeding disorder, and how deep do you go?
This depends on the gynecologist, I think, and how they are aware of bleeding disorders. But for sure, again, it's a problem of resources. But if menorrhagia is the only bleeding symptoms and we have low resources, as I said, we probably don't even need to investigate the patient, because our treatment will not change. But if you have a patient with menorrhagia, and then she had a problem of clinically relevant epistaxis during the infancy, and probably she had necessity of going back to the dentist after tooth avulsion. In that case, you need to investigate a bleeding disorder. And as I said, my desire would be to offer everything, not in steps, because medicine does not go by steps. It's resources that go by steps. So if you can offer everything at the beginning, and so you can see what's the problem. Otherwise, of course, von Willebrand disease is the first thing to evaluate, and then platelet disorders, and then all the most rare things.
Thank you. Dr. Ankit, please.
Yeah, thank you, sir. So all the questions that I had in mind have already been answered. So I'll just ask one off-bit question. How do you calculate the dose for VWF factor in a patient of VWD planning for surgery? Do you go by VWF level or by factor 8 level? So in India, we have both the combinations available, both the brands available. So either of them suggest a different methodology. So what do you do? What is your preference?
Okay. Of course, it depends on the type of von Willebrand disease. So type 3 is the easiest because everything is low, and you can use a von Willebrand concentrate that has a ratio 1:1. And of course, I aim if the surgery is high risk for 100% before surgery, so I can then go down and treat the patient at the beginning every 12 hours and then probably every 24 hours. If I have a patient who is probably 60 years old, type 2M von Willebrand disease, so he or she has normal levels of factor 8 and low levels of von Willebrand factor, I tend to aim for 100% of factor 8 and also 100 or more of von Willebrand factor, using most cases Hum8P that has more von Willebrand factor. I don't have any problems in saying the brand because we are all doctors, so we know we must make a choice. And in that case, what I do is I daily check, or every 2 days, the levels of factor 8 and ristocetin cofactor to be sure that both are enough, but in case of factor 8, not too high. That is what I do. It will be different when recombinant von Willebrand factor will become available. it will be very interesting, because in that case, we can really decide what we want to give. If we want to give only von Willebrand factor or factor VIII as well, and which, how much. We also have available from just Vilfactin that is only von Willebrand factor. Since it's quite difficult to obtain it in Italy now, they had some problems with the production in the last 2 years. We tend to use that only for those patients who are quite old, have really normal factor VIII levels, and have probably a thrombotic risk, like probably some neoplasia, cancer, or stuff like that.
Thank you.
Thank you, Dr. Ankit. Before we go to Dr. Abhishek, one more question from the audience. Dr. Chikodi wants to know, in a patient of HELLP syndrome, do you investigate for coagulation factor S's?
Not routinely, because with the HELLP syndrome, the situation is so critical that we have other problems at the moment. If the bleeding is very acute, something that I tend to do, even if it's not in the guidelines, but I had the need to investigate several times, is to investigate factor 13 levels. If you have a very acute bleeding problems, factor 13 will go down, and the clot will not be competent anymore. So you will need to use tranexamic acid and probably some plasma. This is also true in chronic DIC. For example, if you have an aortic aneurysma with a leak syndrome, in that case, you can have a bleeding problem due to the consumption of factor 13 and the alpha-2 antiplasmin, and you can have bleeding in the muscles, spontaneous bleeding in the muscles, if the level of factor 13 and alpha-2 antiplasmin are less than 30%. So not a very severe deficiency, but I'd say that in that case, in those cases, can become clinically significant.
Thanks. One more question from the audience. Dr. Tanuja has a case of type 3 von Willebrand disease. A woman who has undergone mechanical mitral valve replacement. Now she needs lifelong anticoagulation. What will be your approach?
I would have chosen a biological valve. I don't know how old is the woman, but a mechanical valve in type 3 is going to be a big problem. Unless the woman was really young, because you have to put the patient on prophylaxis and then try to anticoagulate. Otherwise, we have really no idea how to deal with these kind of problems. In patients with the type 3 or type 2B, 2A von Willebrand disease, when we have atrial fibrillation, for example, that is a problem of old age, what we tend to do is to close the auricular, the part of with just the device, so we can avoid anticoagulation. But a mechanical valve in a woman with type 3 is going to be... What Professor Mannucci always said in the past is put the person on prophylaxis and consider it to be like a normal person. But this is not something easy to do, because probably you will need to treat this patient every 2 days, and the expense will be very high. So I'm not sure.
Sure, Dr. Abhishek.
No more questions, sir. Thank you, Dr. Bigos.
Dr. Dheeraj.
Yeah, good afternoon. Dr. Miguchi, I take the one little bit diversion from the main topic. Basically, we are facing coagulopathy problems in COVID. This applies to males as well as females. But the thing is that we give anticoagulation prophylactic if the D-dimer is less than 3000 but above 500. But if it is more than 3000, we give therapeutic. And what we have observed, a little bit of sepsis element because of steroids or other reasons, lines and all, patient will invariably lead to bleeding problems. We stop the anticoagulation and then they have clots everywhere, maybe in the lungs or the brain or the heart. So this was a dilemma. Are we over-treating with anticoagulation, whether newer anticoagulation should be used instead of heparin. It involves males as well as females. So this in the COVID pandemic, I wanted to know in this COVID patients, your thought about it.
Thank you for the question, because we had a lot of discussions in our group about it. Basically, last year in Italy, you know that we had the big problem at the beginning when nobody knew about what COVID was. And we were the first to describe these problems of thrombotic complications. My colleague, as I said, I spent 1 year in Leiden, so I was not doing clinical work in Milan at the time. But my colleague showed me the data, and we really had a large number of patients with severe thrombosis to use quite high this year, because there is a big difference in the treatment, that is the use of steroid. Now, when the patient is hospitalized, because they are hospitalized because they have problems with their breathing, so they have insufficiency, we start a treatment with steroid. And I think this is the reason why we do not see so many thromboembolic problems as we saw last year, because the inflammation is somehow managed with the steroids. And that is why if we use the same level of anticoagulation that we used last year, we will see many more hemorrhagic problems compared to last year. And this is something that I try to convince my colleagues of, and I'm having problems. So I try to stay a little bit more behind. I always give regular prophylaxis to everyone, even if they are young, for sure. I check renal function just to be sure that with older people, I do not give too much. Okay, no problem. Then my colleagues, they say, if the level of insufficiency is high, we have to give more. And on this, I'm not so sure. You can check the D-dimer, can be a threshold. I can tell you that in the respiratory ward, where we have the cases that are most severe, they use a lot of steroid, methylprednisolone, 80 milligrams per day, or even 120, that is really a high dose. And if you keep them on anticoagulation levels, because you anticoagulate them, sooner or later you will see a hemorrhagic problem, but bad.
Yeah,
so I try to stick to prophylactic doses, or let's say generous prophylactic doses. Therapeutic, if they do not have the thromboembolism, I'm a bit worried, because if they then bleed and they have a severe bleeding, you cannot give even prophylaxis. And then the thromboembolic problem is going to arrive. That's why I'm a bit concerned. But we have different opinions in our group, where we discuss this almost daily.
So just one more thing, so prophylactic anticoagulation plus small dose of aspirin will help, or even that will increase the iatrogenic bleeding problems?
We don't use routinely aspirin, so I cannot give you my personal opinion on that. I fear that aspirin together with those high doses of steroid is going to be a problem as GI bleeding. My opinion, but I don't have an experience. It's just my opinion.
Thank you.
So there are a couple of questions from the audience related to the question Dr. Dheeraj asked. Your patient is on Claxin in the hospital, COVID infection. While discharged, you continue Claxin or you switch over to Dovax? And how long do you continue the anticoagulation at home if there is no thrombotic event?
So we continue prophylaxis for at least 2 weeks after discharge if there are no thromboembolic problems. If there are, they are discharged on heparin in any case, and they are re-evaluated in the outpatients clinic if they have become COVID negative, and then they are switched to DOACs or warfarin, depends on the case. But they are followed. We try to follow COVID patients for at least 6 months to be sure that all the problem, to be sure what are the long-term problems of COVID in terms of pulmonary fibrosis and so on.
Thank you. Another question from the audience, Dr. Lahoti, is we do not have factor 13 concentrate. So what is your schedule of prophylaxis for a child with factor 13 deficiency who has bled intracranially once?
Okay. Hemorrhage, also the trough levels, and because of course children can have a different PK, pharmacokinetics. So use what you have, cryoprecipitate or fresh frozen plasma, check levels at 15 days, 3 weeks, and 4 weeks. And if you have 1%, you are happy.
This will continue lifelong? Will this continue lifelong?
Okay.
No, that's a question. Will you continue this for lifelong?
Sorry. Yes. For intracranial hemorrhage, yes.
Right.
Absolutely.
Dr. Srimati, you have a question?
Yeah, one simple question. When a new female with low factor 8 level walks in, what is your strategy as far as the diagnosis is concerned and the counseling? Would you go for the whole next-gen sequencing panel? Because there's no family history of hemophilia. She just has come to you with low factor levels.
How low?
Probably 3 to 5%.
So very, very low. Okay. We generally, what we do is we generally go for the more, I would expect to find a mutation associated with severe hemophilia A in this case. So we would check the most frequent mutations for severe hemophilia A. So in our case, inversion of intron 22, inversion of intron 1, and then so on. And then you can go for the whole sequencing. Now we use NGS, so it's easier. Nevertheless, the other thing we do now is we do methylation evaluation to see if there is an imbalance between the two X chromosomes that explains these very low levels in a carrier. This is what we do. We have only one very young girl with a 4% of factor 8. She had a couple of hemarthrosis, but nothing more. She is now 8 years old. The problems will come when she will become a woman, I think, because these levels are really, really low. And I would probably expect to use some kind of prophylaxis to start the pill for sure as soon as possible, and some kind of prophylaxis if the pill is not enough to preserve fertility.
Thank you. Dr. Chandrakala, any more questions?
Practically, this young female with the bleeding disorders, when they come with menorrhagia, the estrogen progesterone pills, what we give for the normal people will not be sufficient. So usually they require about double or three times the dose of what we usually use in the initial period, and then we can taper it down. So do you have any protocol actually, how much do you use in the initial period of menorrhagia, and then how much you will continue and how long you continue actually?
Okay. There were some interesting data from the Atlanta group on the use of intravenous estrogen to deal with the acute bleeding during the menses. We don't use it, I haven't ever used it, but I am thinking that that could be a good option when a girl comes to you with heavy menses, and you cannot, in that case, you need something to stop the bleeding acutely. And they're using intravenous estrogens. I've never used those, but I'm thinking to discuss this with the gynecologist to have it in the emergency room specifically for young women who have this problem. I've never had the need to use double a dose, but the thing is, if your woman is severely anemic, I treat the anemia first, because anemia is a risk factor for bleeding itself. So this is something that women must be aware of and must be really encouraged to deal with this problem, because they are used to be anemic and they tend to stay with probably 8 grams of hemoglobin without complaining. But having 8 grams of hemoglobin is a big risk factor to bleed during the menses. So if you can, treat them acutely with intravenous iron. Ferinjector is a very good option now and is really effective. And generally what we do, more than doubling the dose of estroprogestin, is we give it continuously, as I said, without interrupting it for 7 days, because this is well tolerated, while double the dose can give side effects quite a lot. So what I would say is treat the hemoglobin levels as soon as you can. If you have an acute bleeding, try the intravenous estrogens to really stop the bleeding there. And try first the continuous estroprogesterone pill first before doubling the dose, because doubling the dose is really going to have a lot of side effects, in my opinion. I've never had the need to use it, I can tell you. And I carry on, I educate the woman that the pill that somehow is not very well accepted in Italy due to cultural problems, because, you know, we are a Catholic country, and the pill was not accepted by the church for ages, and even now is not so well considered. I try to educate the women that the pill is their therapy for their bleeding disorder. They must not stop it unless there is a very important side effect, or if they want a pregnancy. Then I say we will discuss together how to approach the pregnancy, because if you do not do it, if we don't do it together, we are going to have problems then. Because of course it's one thing if they have the pregnancy within 2 months, they stop the pill, or if they have to wait 12 months because probably they're not really looking for it, but they still bleed every month. That's my experience. I'm not sure if I helped you or not.
Thank you, thank you.
Thank you, Dr. Chandrakala. There are 2 questions related to GI bleeding. One in a case of von Willebrand disease with angiodysplasia, and one in case of hereditary telangiectasias. How do you decrease their GI bleeding?
Okay, I just answered the second question about Rendu-Osler disease, the hereditary telangiectasia, because I heard an oral communication at the ASH meeting that was really interesting, and it was the use of bevacizumab in this kind of patients. It was really, in their data, it was really effective. It's still a study, of course, but I think that is the strategy to go for an anti-VEGF therapy. So I think that in patients with von Willebrand disease and angiodysplasia and GI bleeding, this could be also a strategy. And unfortunately, we don't have data. In my personal experience, I had patients with type 3 that responded to prophylaxis, but after some time. So I had to wait for 12 months before the GI bleeding was really stopped. And I think this is due to the effect of prophylaxis probably on the vessel that takes some time to happen. So if I have a patient with type 3 von Willebrand disease, GI bleeding, and angiodysplasia, I start as soon as I can, as I make this diagnosis, a prophylaxis, even if probably the number of events is not so high, but because I want to have the time to get the prophylaxis to get to be effective. My problems in the past were with type 2A and type 2B patients. especially those with cirrhosis, where probably there was also a problem of hypertensive gastropathy, worsening the GI bleeding. And I have now one patient who is transfusion dependent, type 2B, despite the prophylaxis. She has a cirrhosis, as I said. She has hypertensive gastropathy. And I think that the von Willebrand problem is only part of the problem. In that case, I keep the prophylaxis on. I tried octreotide, I tried atorvastatin. They didn't make a big change. I used lenalidomide, and that was really useful, but I had to stop it because of leukocytopenia during the treatment. And that was really, really something that made me think that lenalidomide, that basically it's an anti-VEGF therapy, worked so well, and I had to stop it. And the patient went back to transfusion. That was really, really a bad moment of my life.
Thank you. Any question from Dr. Ankit, Dr. Dheeraj?
No, sir.
Yeah, just one question I would like to ask. One lady, say, a couple of decades ago, had developed cortical venous sinus thrombosis on warfarin, whether because of undercoagulation or maybe having more risk. The lady gets a pulmonary embolism, and then they work up and found to have APLA. So now she's on warfarin plus aspirin and had a recent subdural hematoma. Now this lady, when do you start the anticoagulation after treatment of the subdural hematoma? And later on, do you give only anticoagulation or only aspirin or both, or whether you'll prefer now DOAC plus aspirin? So that's what the dilemmas are. This lady has turned out to be APLA when the pulmonary embolism happened, when they worked out up properly.
Okay, the problem, I think, is to evaluate if the subdural hematoma was post-traumatic or not.
Do you know?
So it was spontaneous.
Spontaneous. Then that is going to be difficult, because if it's post-traumatic, I'd say stop the treatment for 1 month, and then you can gradually restart it. If it was spontaneous, then the risk of rebleeding is really, really high. If I got it right, this lady had a cerebral venous thrombosis, right?
Yes.
Yeah. The beginning event was a cortical venous sinus thrombosis, and because of the pulmonary embolism, additional to the warfarin, she was put on aspirin also.
I wouldn't start again both treatments for sure, because the risk then is too high. Choose one of those. Probably the anticoagulant is better, but I'm not sure about that.
So in the anticoagulant, would you choose a DOAC? That is the question. Because of convenience sake, or just because we don't have much data in APLA, you'll continue with warfarin with INR monitoring. What?
Okay, the data on the better performance of DOACs really refer to intracerebral bleeding, not to subdural hematomas. Nevertheless, I'd say a DOAC is okay, but keep the patient tightly attached to your center and reevaluate the patient every 3 months, so that if something new happens, like a renal insufficiency or something like that, you can check it. At least check the renal function every 3 months, and check it personally, because we see a lot of bleeding events related to subsequent renal insufficiency. These DOACs are very convenient, but they are not with 0 bleeding events.
Okay, thank you.
Just one question. Are DOACs okay for antiphospholipid syndrome, or you insist on warfarin?
We insist on warfarin.
We insist. Ankit, you have a question?
No, sir. No, sir.
So I think that's the end of all the questions. Ma'am, extremely delighted with the question and answer session. It was great. All questions were also very intelligent, and your answers were super intelligent. He really learned a lot. Thank you so much for this very, very interactive session after a great talk. We will probably keep bothering you in future and try to even invite you to India. And thank you so much.
It was a pleasure sharing with you all these cases that are, and thank you for the questions that are really interesting. And let's hope to discuss it again in the future.
Thank you. Have a great day ahead. Thanks to everybody. Okay, bye-bye.
Thanks. Bye.